Our next presenter is Shel Gross. Shel serves as Mental Health America of Wisconsin's Director of Public Policy. In that position, he leads systems-level advocacy around mental health issues. Shel also serves as chair of the Wisconsin Council on Mental Health, which is working on a 2-year effort to bring together the main players in the mental health system, including consumers and family members, to define common priorities and goals. Since 2004, he has headed Mental Health America of Wisconsin's effort to lead a statewide infrastructure for suicide prevention. He is also a founding board member of Wisconsin's statewide mental health consumer group called Grassroots Empowerment Project. Prior to joining Mental Health America of Wisconsin in 2000, Shel worked for the Wisconsin Department of Health and Family Services for 10 years as the Mental Health and Substance Abuse Planning Analyst in the Wisconsin Medicaid program. Shel is a graduate of the La Follette School of Public Affairs at the University of Wisconsin-Madison, and we're very grateful to have him here. Shel.
Okay. Okay, I assume my slides will show up, or do I just click? Okay. Thank you all. I'm glad to see all of you here today. I'm thrilled to come on after Chuck. I don't know if his bio included that Chuck used to work for our national organization, Mental Health America, so we've known each other for quite a number of years. It's been really nice to catch up with Chuck last night and this morning a little bit. And I'm also a big fan of the work they're doing in their Center for Integrated Health Solutions that he mentioned, their TA center. We've been doing a lot of work on integration here in Wisconsin since about 2004, and the pace of change in that area has just been incredible. There was very little going on 8-10 years ago, and now we've got the Affordable Care Act that's institutionalizing it. And we, last month, actually, I had advocated strongly to get one of Chuck's colleagues from the center here in Wisconsin to meet with our Medicaid mental health folks, because they are looking at doing health homes for people with serious mental illness, and I knew that they had a lot of expertise to share. And we spent a day with Kathy Reynolds, and it was very useful for our Medicaid folks, so I appreciate the work that you guys are doing. So when I was asked to speak, I said one of the things I wanted to do is, you know, I'm supportive in integration, but when we think about 21st century trends, it's not limited to integration. There's, I think, a lot of other things that are happening that I want to be able to touch on this morning. And as a disclaimer, I should note that I do not have any special psychic powers. I'm just like the normal person when it comes to that. And I don't know how many of you are familiar with William Gibson. He's one of my favorite futuristic novelists. And he manages to write novels that are kind of in the future, but they're kind of not. And they really embody this idea that he has that the future is already here. It's not evenly distributed. And the trick is understanding what parts of what we're seeing are really going to become our future and what parts are evolutionary dead ends, as it were. And what I want to do is walk through a few things that have really struck me in the last couple of years as probably what I hope the future will be, since I don't have any particular knowledge about it. Things that I think are very provocative and potentially extremely transformative, and I hope that you'll find that to be the case as well. But before I do that, I was really asked when it came to talk a little bit about conceptualizing integration in the larger frame of public policy in Wisconsin, and also talk a little bit about parity implementation, so that I wanted to do that. And what I wanted to talk about in order to do that is the mental health non-system. And right now in Wisconsin, when you look at mental health, especially in the public sector, you see something that's kind of like this. You have somebody who is in distress and not knowing what to do, not knowing where to go, and any one of a number of things may happen. Starting up in the upper left, we have a county-run public mental health system, so the person may go to the county, And depending what county they're in and what their presenting problems are, the county may determine that they are able to serve them. And depending what county they're in, the county may have the particular sorts of services that would actually be useful to that person. And there actually may be slots open, or there may not be. If the person has private insurance going clockwise around the circle, they may seek to get services through their private insurer. And as I'll talk about when I talk about Parity in a bit, they may be successful in getting some services. Again, not necessarily the services they would really need, but what that plan has available to them. They might not get as much of the services they need, but they may get something. Or they may go to primary care, and as Chuck just talked about, if that primary care practice is one that is part of that pocket that's in the future, they may do a pretty good job. But if it's like most primary care practices, again, they're probably not going to get what they need. Often they'll go to the hospital, to the emergency department, may get something, but as many of you know, that's not a very ideal place to get treatment for mental health disorders. And then many people may end up developing a relationship with law enforcement, whether they like it or not. And the downside is law enforcement, unfortunately, has had to become good at working with people with mental illness. The upside is they're actually becoming much better at doing that, but they're not treatment providers. And there was, a couple of years ago, the State Department of Health Services contracted for a study of the public mental health system called the Mental Health Substance Abuse Infrastructure Study. And they really confirmed that our system looks something like this. It's fragmented, it's very uneven across the state in terms of access to services and what people can get when. Now, in my mind, ooh, that didn't move when I did this. This must be an advanced thing. Okay, cool. So in my mind, what a system ought to look like is something like this, where if you have a problem, you have a place where you know you can go that helps you deal with that problem. And then you get an assessment from a qualified provider, or maybe somebody who will be a qualified provider in the future. If it's a public mental health system, then you have usually a team who's helping you figure out what do we need to do to address this problem. Some of it's medical and some of it's psychosocial. And then you also want to have the natural supports that sometimes fall down and sometimes don't. And then as Chuck talked about at the end, you want some sort of evaluation process. You want to know how is this working for that individual and how is this working for the whole population that that system is serving. That's what a system ought to look like that has a chance of being effective in helping people. It's not what our system looks like right now. So there actually are recommendations that came out of this infrastructure study and a number of many meetings of a number of work groups that followed that to do a number of things. One was to really try to identify what are the core services that ought to be available everywhere in the state. That there ought to be enough funding so there's equitable access everywhere in the state. So it doesn't matter if you're in Milwaukee County or Marathon County or Bayfield County, you go to the county or the provider's contracting and you can get this certain array of services and you'll be able to actually access them. And there should be measurable outcomes that are meaningful to the system, but also outcomes that are meaningful to those individuals who are seeking assistance. And there's a number of ways, things we can do to help to get to this new kind of system, and integration is one part of it, and the sort of stuff that Chuck talked about is one piece of it, and there's some of that going on. We do have counties and FQHCs in Wisconsin starting to work with each other. We do have models of collaborative care, again, that are happening some places. That's some of the future that is already here. There's also other things being looked at, like regionalization of shared services to create better economies of scale, and really refashioning some of our psychosocial rehab services. And there'll be an RFP coming out from the state probably in the next month for counties to start to pilot some changes in the system to create more of a system. So so I want to locate integration as part of the solution to the fragmentation we have right now in our larger public system, as well as within the private system. As far as parity, you know, we were all hopeful, some of us more so than less. Yeah, we know, looking at some of the states that have been leaders in implementing parity, that it didn't fix everything. But the Government Accountability Office did do a study of the implementation of federal parity. This came out last November to see what was actually happening out there. And they found a few things. One is that only 2% of employers reported discontinuing coverage. Now, this was not surprising in as much as prior to the passage of the Domenici-Wellstone Act, we knew that the vast majority of employers were offering mental health and substance abuse. It was pretty well entrenched as part of the package of services in most plans. And there have been surveys to suggest that, in fact, people weren't looking at dropping those services, and in fact, that hasn't happened. There has been a significant decline in employers reporting limits on visits, in this case outpatient, but also inpatient. That's good, because that's what the law requires, so it does seem to be working in that sense. It has reduced enrollee out-of-pocket expenses, and that was one of the big impetus for it, that the real consequence of not having parity was people who needed significant amounts of mental health treatment were paying a lot more money out of pocket, because, you know, their treatment ended, their payment ended at some point, and their treatment did not. And so that has been ameliorated to some degree. But there's still mixed data on access to services. So all that being true, it's still not clear whether people are actually getting more services with parity. And part of the reason, and I think probably a big part, are what's called the non-quantitative treatment limits. So parity said you can't have differences between mental health care and physical health care in a whole variety of ways, and some of those are pretty clear. You can't have fewer outpatient visits allowed than you would for typical other benefits through your health plan. You can't have different payment limits, as we had in Wisconsin, where you had the $7,000 per year limit. Those are pretty clear, but it also technically impacted non-quantitative things, like what is the process for approving continued hospitalizations, or what is the process for approving continued outpatient treatment. And in this area, I think that anecdotally, what we've seen is that because the quantitative limits are off, that plans are looking to these non-quantitative measures to control treatment utilization. This is not surprising to us, but the failure to see any change in access suggests that is happening. My personal story is a very, very good friend of mine who is a psychotherapist in Madison, who used to complain to me without end before the parity law was passed about how horrible it was, because her clients, you know, you always get to August and September and they'd run out of coverage, and then the last part of the year, either she had to cut her rates to accommodate them or they weren't getting treatment. Well, she complains even more to me now than she used to before, because the plans are scrutinizing her care so much more. So at least before, she got 20 sessions and they didn't complain about it very much. Now it's like they'll give her 5 sessions, and then after that, she has to spend a lot of time justifying why she should get another 5 sessions and another 5 sessions, and she's dealing with a very difficult population of clients. So, you know, as far as she's concerned, parity is not working, certainly not working for her, and she doesn't think it's working very well for her clients. And unfortunately, politics being what it is, although there have been some rules issued, there are a lot of things that have not been clarified at the federal level. There's not enforcement that's really going on around this, and there's going to be some hearings, field hearings sponsored coming up this summer to try to ratchet up pressure on the Obama administration to really make sure that parity is being implemented in the way that it was envisioned. Now, I guess for those of you who are providers, this is probably not surprising news, and it's unfortunate, but it just shows, as often is the case, passing a law does not necessarily fix the problem, and we have work to do. And again, integration can be part of that, because if they're in primary care, they probably don't have those same limits that they've got in behavioral health care, and so it may be a way to slip around some things. But again, some people are still going to need specialty care. So that's that fulfills the obligation that I was primarily asked to do. Now I get to have some fun and suggest some things to you about the future. And one way to look at the future popped up, I don't know, it was probably 8 years ago, when at the state level, the Mental Health Authority changed its name. And I thought this was a significant glimpse into the future in and of itself. We used to have an Office of Mental Health and an Office of Substance Abuse Services in the Department of Health Services. And there was a growing recognition and push to really integrate mental health and substance abuse treatment, because we know that very often the same individuals who need both, but they were often in a position of trying to get substance abuse services here and mental health services there, or maybe not getting either because this provider said, well, you got to get that taken care of first. And we knew that that wasn't working. So there's been a lot of development in integrating that. And so they wanted to integrate those two offices. But in doing that, they also wanted to integrate a different way of thinking about what their oversight addressed. And prior to then, the State Office of Mental Health was really focused on adults and kids with the most serious mental illnesses. That's what our public health system, mental health system, is tended to serve. But as they brought these together, one thing that was clear on the substance abuse side, prevention was always a big part of the substance abuse world. It was understood what prevention meant, and there were a lot of dollars going toward prevention, but prevention was hardly ever addressed on the mental health side. Mental health disorders were viewed as genetic primarily, and so the work that was going on with prevention was really around trying to understand the genetics and what we can do around that, but there was very little else going on. The treatment part obviously stayed the same, because that remained a big part of what the mental health system needed to do. But over time, the other thing that really developed, again on the mental health side, because it was something that's always existed as well on the substance abuse side, was the notion of recovery. So recovery from substance abuse meant not using and continuing to get the supports to not use. On the mental health side, it meant something a little bit different about being able to live, productive, meaningful life with, a mental illness, but not being defined by that mental illness. And so in changing the name, they wanted to incorporate that they weren't just looking at treatment and serving people forever in a treatment system, but really the idea that you could recover and you could live a full, meaningful life despite having a mental illness. And so that name change, I think, was something that spoke to where the future was going. And I want to use that as a rubric for talking about some of the ideas about where we might be going in each of these areas. So as I said, in the area of prevention, we haven't really had a whole lot of real primary prevention in the area of mental health. But one of the things that's starting to emerge is some of the early intervention that can make a difference with kids in terms of impacting the likelihood of them developing mental disorders. And one thing we know, with resources being what they are, with not a whole lot of likelihood of seeing increases, much less maintaining our treatment resources, if we don't shut off the spigot a little bit and start reducing the number of people who are coming into the system, we're going to be just obviously in worse shape as we move ahead. So there's an intervention called the Good Behavior Game that was developed as a classroom management strategy for first and second grade classes. And it was really to promote pro-social behavior in that environment. And it was very successful in doing that. But the people who developed the program started to look at following kids who had been in the classrooms that used the Good Behavior Game, and they saw that by middle school, those who played the Good Behavior Game in the first 2 years of elementary school were less likely to be delinquent and in need of behavioral health services. Again, my understanding is it was not developed for that purpose, but when they looked at it, that's in fact what they found happened. And then when they looked further on, kids who were 19 to 21, who were deemed to be high-risk kids from the environments they were coming with, those who had been in classrooms that used the good behavior game were much more likely to attain a high school diploma, much less likely to use illicit drugs, and much less likely to engage in antisocial behaviors. So this is a true preventive intervention that was having very long-term positive impacts on mental health and substance abuse in the lives of these young people. And the thing to me that was really astonishing is in 2010, SAMHSA, the Federal Substance Abuse and Mental Health Service Administration, started giving grants to schools to implement this intervention. So we were talking about, at the highest level of our mental health system, funding true prevention services. So this to me was a really a landmark in terms of looking at prevention as a part of the mental health system and an important part of what we need to be doing. The other thing that's really exciting stuff, for those of you who are not familiar with, is the studies that have been done around adverse childhood experiences. And this arose out of work at Kaiser Permanente, as a lot of stuff seems to, where they were trying to understand why some of their members were not responding to various kinds of interventions for chronic health conditions that other members were responding to and that had a good track record of being effective. And so they did a survey of 18,000 of their members, and I'll talk about that in a second. We have now actually collected data in Wisconsin through the Behavior Risk Factor Survey on 4,000 randomly selected adults, which really just confirmed what they found at Kaiser Permanente about the relationship between early childhood experiences and later health status. And the data I'm going to present you is from Wisconsin, but again, it's not unlike what they found at Kaiser Permanente. So these are 8 of the adverse childhood experiences that we looked at here in Wisconsin. There's a couple of others that were not part of the Wisconsin study. And you can see they range from reports of emotional abuse to living with a parent or somebody in the household with substance abuse or mental illness or incarceration. And you could see the various rates of how often those were reported in the population. But what was interesting is when you start looking at the presence of those adverse childhood experiences and the later health conditions. So here is something that is actually a pretty common linear relationship we find throughout a lot of the comparisons. And this is for depression. And what you see as the number of different adverse childhood experiences that somebody reports increases, the likelihood of them being diagnosed with depression later in their life, increases significantly. So from about 7% if they reported no adverse childhood experiences to, 35, 36% if they reported 4 or more. For suicide attempts, we actually have something that looks more like a geometric kind of progression, where as you get more and more of these adverse childhood experiences, you have an even greater likelihood of seeing suicide attempts within the population. And we see similar relationships for anxiety, for frequent mental distress. There's a strong relationship between being on Medicaid and having 4 or more of these adverse childhood experiences. So our Medicaid agency is actually very intrigued by what some of the implications may be of this. And strong relationship with various physical health status indicators as well. Now, we're not saying exactly what the relationship is here. Obviously, if you have a young person whose parent has a mental illness or living with someone with a mental illness, there's a genetic component to that, but there's also an environmental component to that. A depressed parent cannot respond to a young person in the way they need to be responded to. And so in addition to whatever the genetic load is, there are environmental factors that are going to impact the likelihood of that young person developing depression or some other mental disorder. But what's provocative is to think about if we can start having some impact on youth who may be at risk of or who may be experiencing some of these things, what might be the impact on our long-term incidence of mental health disorders. We have a program at Mental Health America called Strong Family Healthy Homes, where we work with families where the primary caregiver has a mental illness or substance abuse disorder, usually both, and we provide advocacy and support, and we arrange treatment for the parent. We do parenting education. We do education with the kids in the families. We provide peer mentors for those people. And what we found in our program is improved parent and family health. We work a lot with families who have kids in the child welfare system. We have an 83% reunification rate, which is pretty significant with where you have parents with mental illness who used to be written off from getting their kids back. We don't know a lot yet about the long-term impact on the kids, but the model is actually developed by another MHA in New York that developed it as a prevention program, recognizing that, yes, the parent has a mental illness, but we can do something about how that environmentally impacts those children. And so we're hopeful that it can make a difference. Yeah, I think about this later when Ron talks about the program that they're doing in Madison. So again, I think there's opportunities for prevention that have not been realized in the mental health field and are critical for our long-term, mental health and for being able to have a manageable system. So that's the prevention part of the rubric. So when we get to treatment, okay, we've got treatment, but we can do better with the treatment that we're doing. And we have some models that are telling us that. And the rubric is evidence-based programs, but it's not just about evidence-based program. It's about a mentality about what we believe we can accomplish with treatment in the mental health field. So this is really another example to me of a real game changer in the mental health area. The Henry Ford Health System is an HMO in Michigan, and they decided a number of years ago that they wanted to do perfect depression care for the clients who were coming into their behavioral health system. And so they started to talk about what that would look like, and one of the things they decided is that they were doing perfect depression care, nobody would complete suicide. And so they adopted that as their goal, to eliminate suicides within their behavioral health population. And the way they went about doing that was not rocket science. They didn't invent anything new. They looked at what was known about doing suicide risk assessments and adopted some assessments that they were comfortable with. They had defined interventions for each risk level. They trained all their therapists in cognitive behavioral therapy, which was known to be an evidence-based practice for people with depression, suicidal ideation. They did very aggressive means restriction because means matter if you're doing suicide prevention. And they were very conscientious in applying all of this very systematically. So within their system of 200,000 lives, the population rate of suicide in the general population is about 12 per 100,000 people who complete suicide. Within a mental health population, it's almost 20 times that much because mental illness and substance abuse are the primary risk factors for suicide. They actually started out below that at 84 per 100,000 in their population. Within 4 years, they had reduced that to 22 per 100,000. And after that, they went 2.5 years without one suicide in their behavioral health population, in a population of 200,000. And I think that still continues. This is a while ago. So I think they're beyond the 2.5 years of no suicides in their population. Now, one of my hats is I'm co-chair of our state suicide prevention coalition. And if you would have asked me 2 years ago, can you prevent all suicides? I would have said, well, you can prevent many suicides. You could probably prevent most suicides if we do things well. But I did not even have in my head a goal of we can prevent all suicides. And what they really demonstrated is unless you have that goal, you're not going to reach that goal. And if you actually do adopt that kind of thinking, you have a chance of getting there. And Donald Berwick, who was subsequently with the Center for Medicare and Medicaid Services for a little while, but was then at the Institute for Healthcare Improvement really, credited the systematic application of evidence-based services as being critical for this. So along with the attitude of we can do it, there has to be a real systematic approach. And I think there's clearly a message here around suicide prevention, but I think with regard to mental health treatment in general, we know a lot more than a lot of people give us credit for knowing about how to help people, but we are not always applying that in a systematic, comprehensive fashion. Some of that has to do with financial resources. It has to do with a whole bunch of things. But I think what we have to do is we have to be believing that we can be doing a much better job and convincing other people that we can do that as well. And I think, Chuck talked about what we can bring to primary care, what we can bring to other systems like criminal justice and places where people with mental health disorders unfortunately spend too much of their time. Now, I have a couple of slides I'm going to pass over here about a project in England, sort of reinforces, it's not quite as dramatic, what the Henry Ford Health Systems did, but it reinforces it. Oh, I guess we didn't get my new PowerPoint up here. But before I go to that, what I want to just mention is that the National Action Alliance on Suicide Prevention put out a report recently called Suicide Care in the Systems Framework, and they looked at Henry Ford Health System, and they looked at 3 other systems that had shown very strong improvements in suicide care, and they found 3 principles that were common to all of them. One is the core value, that suicide is a never event. One is the systems management that I talked about. One is the use of evidence-based care. And they put out, I really recommend this document to anybody who wants to really see something, which I think 20 years from now we're going to recognize as a seminal document in suicide prevention. And it outlines guidelines for primary care, for behavioral health, for emergency departments and crisis services, and how they can start to implement some of this new way of thinking. So that's the treatment side, and I think that it shows that we can do better, and we obviously need to do better than what we're doing now. And having those examples is important because it really changes the way you have to think about this. Well, you don't have to, but I'm suggesting you should. So, okay, the last part of the rubric was recovery. And the idea of recovery is that there's a process that people with mental health disorders can go through, where, as I mentioned before, they can live a self-directed, meaningful life despite having a mental illness, even if they have symptoms regularly from time to time. We all have symptoms of all kinds of chronic conditions that we learn to live with, and people with mental illness can do that as well. And that one of the important components of a recovery-oriented system is the use of peer-operated supports and services, that they are an adjunct to the system. They don't replace the professional system. They're a little like hamburger helper. They can make the professional system go a lot further than it currently can. And again, with limited resources, that's very important. And I would say beyond important, I think it's critical. Peers bring something that professionals can't, which is a modeling of the fact that I was once where you were, and I'm not anymore. And that means you can be someplace different than you are right now. And professionals can say that, but peers can show that. And that's very powerful. And it's part of why peer programs work. There, you have the reference sheet. These particular studies are from a review article that Judith Cook did in the Psychiatric Rehabilitation Journal. There are a lot of other studies that affirm that peer-run services can be as effective and when combined with professional services can be more effective in helping consumers reach their treatment and life goals. And so they're very important. We have a non-peer-reviewed study that actually happened right here in Wisconsin, so I want to mention that. And that is PeerLink, that Optum Behavioral Health worked with our statewide consumer group, Grassroots Empowerment Project, to provide certified peer specialists for people in Optum's system who had high use of psychiatric inpatient services. And they found over actually a relatively short period of time a 46% reduction in hospitalizations among that group of people. Now, if you remember Chuck talking about the Medicare incentives to reduce hospitalizations, wow, you could have a fairly low cost. You got to pay peer specialists, okay? I got to put a plug in for that. They're valuable, but you don't have to pay them as much as a psychiatrist, and they're very effective in this kind of venue in working with peers to make sure that they're adjusting to their life, following through on what they need to do to remain in the community. And my understanding is that even though it's not a double-blind controlled study, Optum was convinced enough that they're going to make this a part of their standard operating procedure, and we're really going to push with Medicaid that they should be asking other managed care organizations to use peers as well. And peer services are really becoming more professionalized. We have an association of peer specialists in Wisconsin. There is a set of core competencies. There's a training program. There is an exam that people have to go through to become certified peer specialists. And there are 170 some peer specialists who have passed the exam. They're working in CSP programs, they're working in crisis, their independent living centers are utilizing them, and that I don't know how they're being utilized in this part of this neck of the woods, but I'm sure there are additional opportunities to have peers involved in helping to build the infrastructure of your system in the future. So, prevention, treatment, and recovery. I have one more vision of the future, and this is one that came unbeckoned a few years ago. We've gone through a lot of stages of sort of how we understand mental health and what happens to people with serious mental illnesses in my lifetime. So I wasn't a professional during all this, but when I was born in 1950, the standard operating procedure was people were spending most of their lives in state institutions or asylums of some sort. And although the asylum movement was well meant, it was not actually producing very good outcomes for those individuals. We know with the introduction of the first generation antipsychotics, Thorazine and its cousins, that people were able to move out of those institutions, but not necessarily into anything. And Mark Brown gave some of this history last night as well. A lot of them ended up homeless. A lot of them ended up in the criminal justice system. But over time, we developed community-based programs to support people in the community. I call that our Clients for Life stage of the system. And that's a term that was actually the title of a documentary that was done by Wisconsin Public Television about the community-based mental health system in Madison, where the Assertive Community Treatment Program began and where I worked for a while in my career. And being Clients for Life was considered a good thing because they were clients for life in the community. They were getting supports they needed, but they weren't necessarily fully integrated in the community. Maybe they were working, maybe not. They had some kind of supported housing, but they were still clients and there was still that mentality. We're now into what I see as the recovery-oriented care phase of mental health, where we understand that people may be now in the public mental health system, but maybe don't need to be there forever. As they recover, can move out and do things that everybody else does. But there's a next stage that I saw a while ago, and this is about Andy Werlein, who's actually going to speak at a fundraiser we're having next week. And I met him actually through his father. And Andy, when he was in high school, which is not an unfamiliar story for a lot of young people, first evidence signs of serious mental illness, was very ill for a number of years, in and out of hospitals, very suicidal. And his dad, of course, had spent down his college fund because he said, the college fund is no good if my son kills himself before he finishes high school. He got a second mortgage on his house. And Andy's father became a great advocate for parity because he understood very well what the lack of parity meant for families. But they stuck it out, and Andy's treatment was ultimately effective. And he, after graduating from high school, gave back by going back to the high schools and talking with other students about his experiences, tried to counter the stigma around mental illness, convince other teens that treatment did work and they should get help. And as a result, we nominated Andy for an award that our national organization gives to young people who are doing advocacy. And so we got to take Andy to our national conference one year. And we were sitting at the opening reception eating finger food with some people I had never met before from some other parts of the United States. And one of those people asked Andy if he was a consumer. And Andy didn't know what the person was talking about. And I had this vision. I said, we can live in a world where people develop a mental illness, they get treatment, and they go on with their lives. They're not stuck in a system for years and years, so they develop this mentality of being a consumer or being a person with mental illness. They get better and go on with their lives. I don't know if that will be what the future is like. I hope that's what the future is like. I think we have the capacity, I know from Andy's story, we have the capacity to get there. And so this, along with everything else, I hope it is a challenge, an inspiration for all of you to think about how can we get to that future? How can we normalize this so much that we don't have people who define themselves as being people who receive mental health services? Okay, I did pretty good, huh, Rowan? Yes. Okay, so I don't know if I have time for questions. Do I have time for questions, or was that it? It's either questions or a snack, and I'm not going to get in the way of your snack, so.